Hi, and welcome to the second part of a two-part series on dementia. Part 1 focused on the various types of dementia, which we will be reviewing in this presentation also. This presentation is titled Caring for Someone with Dementia, and it will describe some techniques on caring for someone who exhibits behaviors as well as medications used for those that have dementia. This presentation is supported by Spirit Lake Senior Services Program and Devil's Lake, and is part of an ACL grant titled Dementia Capability in Indian Country. It is co-sponsored by Dakota Geriatrics from the University of North Dakota's Rural Health and the University of North Dakota's College of Nursing and Professional Disciplines. My name is Dr. Karen Simmons. I'm a faculty member from the University of North Dakota's College of Nursing and Professional Disciplines, and I hope you enjoy this presentation. We will be talking about we're going to recall the 4 different types of dementia. We're going to understand the differences between the different types of dementia, and we're going to touch just a little bit on delirium, and those are both reviews from the first presentation. We're going to identify the need for providers for geriatric dementia care, recognize the 5 A's and how the behaviors relate to the 5 A's, and identify different types of behavior management. So first, let's review the various types of dementias. We're going to review Alzheimer's disease, vascular dementia, dementia with Lewy body, and frontotemporal dementia. So starting with Alzheimer's disease, which is the most common cause of dementia. Researchers have identified that there are plaques in the brain, known as beta amyloid or neurofibrillary plaques. Beta amyloid is a protein that forms sticky plaques in the brain and forms tau tangles, which cause brain cells to die. These plaques and tangles can be seen on an autopsy. The greatest risk factor of Alzheimer's disease is age. It can start as early as in the mid-60s, and the risk factor goes up as the person ages. It is considered a terminal disease, and at this time it is considered the 6th leading cause of death. Depending on when the disease is identified, from diagnosis to death can be as little as 3 to 4 years, or it can be as long as 10 or more years. And there is no cure for Alzheimer's. Vascular dementia is considered the second most common type of dementia behind Alzheimer's. In Alzheimer's, we see a slow progression, as if going down a hill, as the disease progresses. With vascular dementia, it's more like going down steps. So there might be a decline in functioning, and then the person might plateau for a while with no behavior changes, and then another decline as something occurs in the brain, and then so on. Vascular dementia can occur alone or with another type of dementia, and sometimes we call that mixed dementia. The cause of vascular dementia is when something interferes with the flow of blood and oxygen to the brain. Things like diabetes, which can cause too much sugar in the vessels. Smoking can cause the blood vessels to get smaller, as can other vascular diseases. There is a strong link between cardiovascular disease and vascular dementia, such as high blood pressure, high cholesterol, and obesity. There's also a strong link with any cerebral vascular diseases, such as strokes. Vascular dementia can possibly be prevented by lifestyle changes. The third type of dementia that we're going to talk about, or that we have talked about in the first presentation, but we're going to just discuss a little bit just as a review, is Lewy body dementia. And there's actually kind of 2 different types of Lewy body. The Lewy body is usually, the onset of Lewy body is usually later on in life. There are 2 different types, like we said. They have similar, but yet a little bit similar symptoms, but just a little bit different timing. So when we talk about Lewy body dementia, there is confusion that occurs before a movement disorder. And the movement disorder is similar to Parkinson's disease. So Parkinson's disease dementia is when the movement disorder starts. So they would have Parkinson's first, and then they have some confusion. So usually it's about a year after things happen. So if there's confusion first, and then there's a movement disorder, that occurs a year after. So first there's going to be some confusion, and then a year later we might start to see some movement disorders, similar to Parkinson's disease. With Parkinson's disease dementia, the movement disorder occurs first, and then the confusion occurs later on in the disease process. So they both, Lewy body dementia and Parkinson's disease dementia, have similar cognitive issues. They have some physical issues such as falls, a sleep disorder, and then some behavior changes. There are visual hallucinations that will occur with some people that have Lewy body dementia will have visual hallucinations, but not everybody. And the hallucinations usually revolve around children. Kind of the hallmark symptom of Lewy body is the fluctuation of cognitive functioning. So one day the person will be functioning pretty good. The next day they might be totally disengaged with profound loss of memory. Kind of reminds me of the movie or the book, The Notebook, where the gentleman goes in and he says, oh, maybe today's the day where his wife is going to recognize him. You know, you think, oh, I wonder if that person was supposed to have Lewy body in that book. We did have an actor. His name was Robin Williams. He was diagnosed with Lewy body. He did commit suicide, and after his death, they did an autopsy on his brain, and they determined that Lewy body dementia was the type of dementia that he had. The fourth type of dementia is frontotemporal. This dementia primarily affects the frontal and temporal lobes of the brain. So the frontal part is like right where the forehead is. The temporal lobes are kind of right above the ears. Those two areas, the frontal and the temporal, are associated with personality, behavior, and language. There is death of brain cells that are going to occur in the brain, and that causes both of those areas to shrink. So the frontal lobe is associated with personality and behavior. The temporal lobes are associated with comprehension of language. So there is a temporal lobe, like we said, on each side of the brain. The temporal lobe on the right side of the brain is more involved with memory. Frontotemporal dementia is a significant cause of dementia in younger people. It can occur as young as 40 years old and up. Tends to progress more rapidly, with an average lifespan of 6 to 8 years of somebody who has this disease. There are no known risk factors for this type of dementia, unlike vascular dementia, which does have some risk factors. Frontotemporal dementia does not. Not that they know of as of yet. There is a risk if there's a family history that has this type of dementia. The risk of others getting this type of dementia is a little higher. What we usually see with frontotemporal is very unusual behavior changes or poor judgment and or some language problems. And the behavior and the judgment is way out of the ordinary. It's kind of bizarre, nothing that the person had ever done before. And sometimes the language problems start before the behavior changes. So with this type of dementia, the behavior changes, the bizarre behavior may occur first, and then the language problems, or the language problems can occur first, and then the bizarre behavior. Bruce Willis, another actor, he's been diagnosed with this type of dementia. He started having trouble with speaking, so they thought that he was having a stroke, and they did find out that with testing that it was frontotemporal. Okay, just to kind of review the stages of dementia. So starting on the left side, no notable changes in the brain with healthy cognitive functioning. The next stage is mild cognitive impairment, or MCI. MCI is when there are more memory problems that begin to develop that are greater than what is expected for normal aging. There is no single cause for MCI. It can occur from diabetes, it can be a stroke, it can be genetic, it can be caused from smoking or alcohol or drug abuse. Not everyone who experiences symptoms of mild cognitive impairment will develop dementia. Some may stay in this stage, for their whole life. Then we have the early stage of dementia. And now we're starting to see some more noticeable memory lapses, but the person can still function independently in their home. So having a little bit more cognitive difficulties than the person that would have mild cognitive impairment. There might be some cognitive issues such as a little more trouble with language, might start to see a little increase in some of the behaviors, might have a little more trouble with some of their activities of daily living, like bathing, dressing, and grooming, and things like that. But like we said, we can still function independently. Then when we get to the moderate stages is where we'll start to see more noticeable behavior changes. They might remember significant details of past events or current events, but they will have some difficulty performing tasks. So kind of at this stage, the persons might start to need some help with some of their activities of daily living or their daily tasks that they do. Safety becomes an issue in this stage. So, the person might decide to wander outside in the wintertime, go outside in the summertime without water and become dehydrated. So it's important at this stage to take all those safety considerations into consideration. So not to say that you shouldn't be thinking about safety in all the stages, but for sure in this moderate stage, when we start to see more of those behavior changes, we need to start thinking of safety things. Does a person remember to turn off their stove? Do they wander outside? Do they leave their door open? Are they at risk for some scams on the telephone? So in the severe stage, there may be a decrease in the ability for conversation and for movement. So kind of deteriorating all the way around. So having problems with chewing, which can result in some weight loss. There might be some seizures that occur as the brain changes. Verbal language might be replaced with groaning or moaning or grunting. May have some more sleep issues, sleeping more. This can result in some skin issues if the person doesn't get out of bed. And because they're having some movement problems, it's not uncommon for them to stay in bed the majority of the time. And like we said, it might cause some problems with some skin issues, so maybe some pressure ulcers and things like that. Also, some respiratory infections can occur at this stage. And that would be, again, because laying in bed or just not moving around, don't clear the secretions in their lungs as they should, can't take that deep breath, can't do those deep coughs. At this point, the person might might need to have 24-hour caregiving, either at home or if they need long-term care services. It is usually in the end of the moderate stage and into the severe stage that the person gets admitted into a long-term care facility. It is really in the best interest of a person with dementia to be able to stay at home just because they're more comfortable, more familiar with their environment. But there are times when the caregiver is not able to do all of the 24-hour round-the-clock care that the person requires. Okay, so that's kind of the end of that review. Just wanted to touch a little bit on delirium. Delirium is reversible. It is usually caused from something else. So you don't just develop dementia overnight. Delirium has a sudden onset. Person could be doing fine, today, tomorrow you see your loved one and all of a sudden they're very confused and they can't remember who you are. They, just very agitated. It is not because they developed dementia overnight. They might have had a stroke, but then you would know that by other symptoms. But usually the underlying causes of delirium is medication. Might be taking too much medication. Medication might be interacting with other medications. Dehydration is an underlying cause, which elderly people are at risk for dehydration anyway, as they just lose that sensation of thirst. And many times it's a medical condition. Oftentimes, with a medical condition, it's a urinary tract infection. And, not having that sensation of burning, if they have, if they're going to the bathroom, urinating, they might not feel that burning that a person younger might be able to feel. Or other types of infections, like a respiratory infection, a virus, something like that. So the infection progresses and the person becomes delirious or very confused because of the infection that's occurring. There might be some thyroid issues. They might also have a vitamin B12 deficiency. So the important thing to remember about delirium is that it is reversible. Dementia is not. So dementia does not happen overnight, does not happen on the operating table. I have gotten phone calls from a friend one time who said that her loved one was in the operating room and came out and was very confused, and the provider put a diagnosis of dementia on their chart. You don't get dementia on the operating table. That would be a medication. A lot of times, if an elderly person goes into surgery and has a lot of anesthetic or any type of anesthetic, that takes a while for that anesthesia to clear out of their body. So they come out of the operating room and they might have some confusion. So again, just have to make sure that we're looking at, is it delirium versus dementia? Also have seen providers give a diagnosis of dementia when the elderly person goes into the emergency room with a urinary tract infection or some other type of infection. So it's really important to do that medical history, to do some lab work and rule out the fact that the person doesn't have some underlying disease that causes them to be delirious. So, okay. So moving on, we're just going to talk a little bit about caregivers. And if you look at the statistics of people who are in nursing homes, usually 5% of the elderly are in a nursing home. So that means that the rest of the people that are needing care are probably living at home. So, and we see that most of those with dementia are living at home. So this becomes maybe a bit of a caregiving issue, because 30% of the caregivers are over 65. So they might be taking care of their spouse, their significant other. Sometimes we have children who are taking care of their parents. Their parents are elderly, and the child is over 65. So what we have to watch for is that the caregiver also takes care of themselves. Sometimes those caregivers might have some underlying issues, might have some comorbidities and different types of medical issues. We have to be sure that they're taking care of themselves too, so that they don't become sick. It does not help the person with dementia to have a caregiver who ends up in the hospital because they're not taking care of themselves. So caregivers may suffer from emotional, financial, and physical difficulties. The emotional part, it is very difficult. That you might hear this from some caregivers, how hard it is to take care of their parent or their loved one who has dementia, because it's not the same person that they grew up with. It's not the same person that they maybe celebrated Christmas with, or whatever. So emotionally, it's very difficult. It's like I said, it's not the same person that you grew up with, and it's hard to watch somebody deteriorate. Financially, the caregiver might have to give up their job to take care of their loved one that has dementia. They might have called in sick a lot. They might have more financial burden from medical bills that are piling up from the person who has dementia and from the caregiver themselves. And some physical difficulties. As the disease progresses, the person with dementia might have or difficulty moving around, like we talked about, when they get into that severe stage. So the caregiver might have to do some lifting, turning of the person. So there might be some physical difficulties of the person who is caring for them. If you're thinking, about 30% of our caregivers being over 65, some people who are over 65 have some arthritis. That can play into the difficulty of moving that elder that has some dementia. So there are some caregivers who fall into the sandwich generation. And this means that they are caring for their young ones or their children, and they're also caring for their parent. So they're kind of in the middle of a sandwich. They are the meat of the sandwich. That can be very difficult because that caregiver is pulled in different directions. So this is where we talk about the importance of making sure that caregiver also has some support and isn't becoming sick because they're being, like we said, pulled in so many different directions. So just a little bit about the providers. It is kind of interesting that 50% of providers say that there's not enough providers who care for those with dementias. So even the providers themselves do not feel like they are comfortable answering questions about dementia, that they don't feel that there's enough of them to take care of the elderly in general, but those people who have dementia. So 25% of the providers do not feel comfortable answering questions about dementia. And this could, be maybe the reason why an elder goes into the emergency room and get diagnosed with dementia, because the provider is just not comfortable running the tests, not knowing exactly which tests to run because they just don't have that experience. There's only 12% of nurse practitioners that specialize in geriatrics. There's only 4% of social workers that specialize in geriatrics. And there's only 1% of RNs, physician's assistants, or pharmacists that specialize in geriatrics. So when we're looking at the number of providers, we can see that there really is not enough providers that specialize in geriatrics or feel comfortable about taking care of someone with dementia. I believe that that is getting better. In the Native American population, they have been doing a really great job of bringing awareness out onto the reservations about dementia and how to care for them. An example of that would be this grant that we're working on here with this Dementia in Indian Country. So when we look at the need for direct care workers, such as CNAs, CHRs out on the tribal CHRs on the reservations, QSPs, quality service providers, that need is projected to rise by 40%. So we're going to need 40% more caregivers to care for our elders and to care for our elders. And because dementia is a disease of the aging, the prevalence of having dementia as a person ages goes up. So within the next 5 years, we're expecting to need 40% more caregivers than we have right now. And that, of course, is because our population is aging. Okay, we're going to talk about the 5 A's of Alzheimer's and dementia. And with each one of these slides, we're going to talk about some of the behaviors that are occurring and some of the interventions that we can do for that person who is having some problems with these types of, with these 5 A's. Okay, so the first A is called amnesia. So forgetfulness is kind of the hallmark number one symptom of any one of these dementias. So the forgetfulness that occurs, and then just that loss of memory, being the short-term memory being lost first and hanging on to some of those longer memories of their lives. So some of the behaviors when the person has forgetfulness and loss of memory is the not recognizing family and friends. And that can be very difficult for family and friends. Matter of fact, it can be very frustrating for the person, that family member who is caring for their elder. Sometimes what happens is the person gets lost. So when we talked about that, as the disease progresses in that moderate stage, that the person might start wandering and then getting lost. And when do we decide to take away their car keys? So then that's a very difficult thing for an elder to have to give up, that loss of independence. So some of the interventions that we want to talk about as far as some of these behaviors. Make sure you always identify yourself, even if you think that they should know who you are. And I have heard family members say, "Well, come on, Mom, you should know me. My name is Karen. I'm your youngest daughter. I've been here. I live with you." It's very frustrating for the person who has dementia to be reminded that they don't remember, who you are. So don't argue with them. Always introduce yourself. Sometimes, the elder might remember who you are today, but might not remember who you are tomorrow. So if you do identify yourself and they'll say, "Well, of course I know who you are. You're my youngest daughter." It's like, "Oh, well, I just wanted to make sure you know who I am." Kind of use some humor along with it. We want to assess what stage of the disease the person is in. And the forgetfulness is going to be progressive. And all 4 types of the dementias have are progressive in nature. So the forgetfulness is going to get worse. The loss of memory is going to get worse. That short-term memory loss, is usually what occurs first, and then the long-term memory loss will start to occur. So kind of assessing where they are in the disease. There's no way to stop any of these diseases other than vascular dementia, which if there are some lifestyle changes, you can slow the progression of vascular dementia down. You can prevent vascular dementia from occurring by using lifestyle changes, stopping smoking, stopping managing your blood pressure and your blood sugar and things like that. But we want to see what stage of the disease they're in, and we want to watch as they progress. So there is no easy way to see how they're transitioning. Today they might, you can't just say, well, today they're in the mild stage and tomorrow now they're going to be in the moderate stage. It's a very slow transition. So one of the things to keep in mind is to keep the environment the same, because they're having forgetfulness. If you keep the environment the same, it eliminate some of those behaviors of I don't know where I'm at type thing. One of the things that I find in long-term care, I'm a long-term care nurse, that when a person who has a dementia comes into the nursing home, the environment is very different and the confusion gets worse. So kind of what I have seen is that in the beginning, when the person gets admitted to the nursing home, the family wants to take them home for Christmas, which is fine, up until the point where the agitation becomes worse when they go back home. Because now, even if they're going back to their own home, and the family will say, maybe argue with the person and say, well, you should remember this is your home. Not always, because as they become more comfortable in the nursing home becomes their home. That's the environment that has stayed the same. That's the environment that is and I don't know, same want to say the word threatening, but it's more structured. So it becomes much more comfortable for them. Removing them from that environment, taking them even back into their own house can be very frustrating, very agitating for that elder. So we might want to think about not bringing the elder home, but bringing Christmas to them. Or, so trying to keep that environment the same. If they're going to stay at home, we might want to look at having a door monitoring device. Something, if there's a caregiver that's staying there 24 hours a day, maybe there's a bell on the door that rings when the door is open. They have those new device type things where you can put like the camera on the door, and when the door opens, it triggers somebody else's telephone. So just some type of a device, knowing that that door has been opened and that it will alert somebody so that they'll know that the person is either leaving, coming or going or whatever. Removing keys for the car is probably one of the hardest things. And it's like we said before, it's that loss of independence. Now all of a sudden they can't drive on their own. They can't go to the grocery store. They can't go to the powwow. They can't go see their loved ones. They can't go to, we have an Elders Day out at Spirit Lake in Devil's Lake, North Dakota. We have many elders that come out for that. So not being able to get there when they want to, having to rely on somebody else when they have been independent in their, very independent in their whole life. So that can become quite an issue. So kind of have to use some different strategies of trying to get those car keys away. Putting the keys, just taking them from the house, moving the car out of the garage, just getting the car out of there in general sometimes is helpful. We'll talk a little bit more about validation therapy and reality orientation here in a little bit. So we'll talk a little bit more about removing the keys and removing the car as we talk about validation therapy. So, okay, the next A is called aphasia, and this is verbal communication. So this is going to depend, vary depending on the stage of the disease that they're at. So again, it's important to know what stage of the disease our elders are at as we're talking about how do we manage these behaviors, knowing that it's going to get progressively worse. So when we're thinking about communication, there's two parts to it. There's the production part, and then there's the comprehension part. So the production part is, as I'm sitting here looking at each slide, I'm thinking about what is it that I want to say about this slide. So that I'm producing the word, I'm producing the sentences. The comprehension part is you on the other end listening to what I'm saying and comprehending what I'm saying. Hopefully what I'm saying is making sense. So there can be a breakdown in the production and there can be a breakdown in the comprehension. There can be a breakdown in one or there can be a breakdown in both. So it is difficult to sometimes talk to some of our elders who have dementia because they might continually repeat the same thing. And that repetitive language can be very frustrating because, oftentimes I'll hear family members saying, you just asked me that question. I don't know what's in the refrigerator. Get up and look, that kind of thing. So it becomes very frustrating when they're continually asking the same thing. It's frustrating for that elder who's trying to figure out what to say, because in the beginning stages of the disease, they know that there is some that there's some communication problems, that they're forgetting words. That one of the first signs of forgetfulness is word finding difficulty. And I'm not saying that all of us don't have that. It's like, okay, what was I going to say here? Your mind is going faster than your mouth. So, but it's continually not being able to find the right word. I remember working at the nursing home one time. I was feeding a resident, and they asked me for put some salt in their coffee, and I said, "You want salt in your coffee?" This is when I was first learning how to take care of people with dementia. And she's like, "No, why would I put salt in my coffee? I told you I want sugar." She got angry at me. Well, I need to anticipate what their needs are. If somebody asks for salt in their coffee, I'm pretty sure that's not what they want, that they probably want sugar. So my better reaction would have been, "Do you want sugar in your coffee?" Instead of saying, "Why would you want salt?" So not arguing with them, but turning it kind of back around, saying, "Is it sugar that do you want? I can put some sugar in your coffee." So that way it doesn't make them feel like they're not expressing themselves very well. Some of the other communication issues can be mumbling. And then as the disease progresses, the ability to express themselves verbally they may not be able to do that anymore. So there might be some of that mumbling, some of that groaning. Again, we need to anticipate their needs. So when we're talking about how do we anticipate needs, we want to look at those kind of meet those 5 basic needs. Are they hungry? Are they thirsty? Do they have pain? Are they tired? Do they have to go to the bathroom? Now, the first word that we learn is the word no. So if I'm going to ask somebody if they have to go to the bathroom, I might not want to say, "Do you have to go to the bathroom?" Because many times that person's trying to stay in the conversation. If no is the first word that they learn, that's the last word that they're going to remember. So they might say no to me, so I don't take them to the bathroom. Well, then they might have some incontinence that might lead to some frustration. So instead I might say, "Hey, let's go to the bathroom before we go to lunch today," or something. So if I'm asking them if they want something to drink, I might not want to ask, "Are you thirsty?" because they might say no. What better question might be, "Would you like some apple juice or water?" So then they can kind of still make a decision, but they don't have to say the word no. So just kind of thinking along those lines. There is some times where the person will revert back to their native language. And it's nice to be able to have somebody who can still speak that language or know at least some basic words in that language that, allows us to communicate. One of the things I thought was very interesting is I had 2 gentlemen, and I do home care. I go out just, to set up some medications and, do some nursing stuff out there. And both of these gentlemen had Parkinson's disease, as they were both Vietnam vets that had been exposed to Agent Orange. And they said this exact same thing to me about 2 weeks apart. And they both were tearful when they were telling me this. And what they said, when we're talking about the production and the comprehension portion, is they said, took them a while to get through this, but basically what they said was that when I would ask them questions, or any one of their caregivers would ask them questions, it took them a while to comprehend what I was saying. So I'll give you an example. So I asked this one gentleman, I was just trying to check his memory and whatnot. So I had asked him, where did he live before he moved, to the town that he was living in? And I didn't give him enough time to respond, maybe give him like 20, 30 seconds. So I asked the question again, where did you live? Because I want to repeat the sentence exactly as I had asked the first time. Still no response. So then I switched the question and I asked, well, what did you have for breakfast this morning? No response, waiting, a few seconds. Asked the question again, what did you have for breakfast this morning? And then he answered my first question. And he said, I lived in a nursing home in, such and such a town. So he said, what happens, he says, is you don't give me enough time to respond, which I realized, okay, I got to give him at least 2 minutes, which is very uncomfortable to sit for 2 minutes waiting for somebody to respond to you. But if that's how they communicate, that's what we need to do. He said, so then what happens, he says, is you're asking me the second or third question. I respond with the first answer, and now you think I'm confused. And I thought, well, that is really significant. And both of them, like I said, both of these two gentlemen, and they didn't live together, but they both said kind of pretty much the same thing to me. And, they said, please tell the other staff to take their time when they ask me a question, because it takes me a while to figure out what they're saying and then just figure out what I want to say. So I just thought that was very significant, and I wanted to share that on the importance of letting the person have time to respond to our questions. We do want to keep sentences short and our requests simple, so that the beginning part of the sentence doesn't get lost as they're trying to comprehend exactly what we're saying. So some other interventions that are related to communication is to speak slowly. And I have a tendency to speak fast, so I have to really think about, slowing down when I'm talking and allowing sufficient time to respond, comment, or ask questions, just like I was saying before. Use calm, reassuring words. Let them know that it's okay if they don't remember, something. It's not, we don't have to get mad at them or anything. We want to avoid harsh tones and negative words. And that would be well, you should remember who I am. I'm your youngest daughter. Or I remember listening to a caregiver at the nursing home arguing with the 85-year-old woman who had dementia. And she'd say, well, you know how to tie your shoes. You've been tying your shoes for this many, 70 some years. I'm not going to tie your shoes for you. Okay, that is not the kind of person that needs to work with somebody with dementia. So, maybe changing up the staffing on that, because that's what we did. We changed the staffing on that. So, but not sounding negative, because they might feel then that we're angry at them. And if we're showing anger towards the elder, they might in turn show anger back to us. Offer no more than 2 simple choices at a time. Apple juice, water, always identifying ourselves or others. Sometimes we might have to help the person find the right word. Like I said, sugar instead of salt. Lightly touch the person to reassure them or calm them, but only if they're okay with being touched. Some people don't mind hugs. They don't mind being touched on the shoulder. Don't come up behind them and touch them if they don't know you're there, because it's possible that you might get hit. So letting them know that you're there. Sometimes I ask a person, would you like a hug? Or if, some people don't like to have their hands rubbed, so, or tapped or something like that. So just kind of knowing the likes and dislikes of the person. Use eye contact if it's culturally acceptable. Some people don't. Some cultures do not make eye contact. I like to make sure that I sit down so that I'm at eye level with the person if they're sitting. If they're standing, then I'll stand up. So that way I don't feel like I'm overbearing if I'm standing and they're sitting, or that they have to, that I have to look up if they're standing, so kind of being at the same eye contact or eye level with them. So communication is a huge issue with those that have any dementia. So, and I like to say a person with dementia versus a dementia person, because they were always a person first before they had the disease. So I don't say the dementia patient. I don't say diabetes patient. It's a patient with diabetes. It's a person with diabetes. It's an elder that has dementia. So, so you'll hear me say that throughout the presentation. Okay, the next A is agnosia, and this is the inability to recognize people and or objects. You're unable to identify sounds, shapes, or smells. So one of the things when we do a mini mental status exam or some type of a cognitive assessment or test, we might ask them we might be holding a pen in our hand and say, what am I holding in my hand? Or we might put a pencil in their hand and say, can you tell me what you're holding? That's that ability to determine whether they can recognize objects. Unable to identify sounds. So if we are, I'm just going to use a nursing home, for example, back in the early 90s when I was working in a nursing home, we had overhead paging, we had telephones ringing, we had all kinds of noises. And it's very confusing for the person who has dementia to have to listen to all those sounds. Now they have dementia units or Alzheimer's units that all that sound is, that eliminated. So there isn't the overhead paging, there isn't the telephone ringing, and things like that. So kind of get rid of all of that extra noises. If we're caring for somebody and the TV is on and we want them to do specific tasks, we want to turn the TV off or the radio off. Unless you find that having the radio on or there's certain music that they like calms them, then that might be something that that you want to use. But knowing that all of that, trying to keep that environment simple, if there's all this extra noise going on, it might be confusing. Sometimes if we have a lot of family around and they're all visiting, my family is Czechoslovakian and we all talk at the same time. So nobody really knows what the other person is saying. Well, that can be confusing if the person has dementia. So they might not be able to identify the smells. So this could be a problem if the person is living at home and they have food in their refrigerator and the milk has gone stale or rotten, or there's rotten meat in there, not being able to see real well because they might have some visual problems, but can't smell that the meat is rotten. They cook the meat up and then they'll, maybe have some food poisoning or something like that. So just kind of keeping in mind that all of these things can relate to behaviors, can have some difficulty, with their physical functioning too. So, so if you can't recognize people, the person who has dementia can become very fearful. I don't know who this person is. They're coming into my room. I don't know them. They keep telling me that they know me, but I can't believe that because I don't know who they are. So there can be some increased confusion as, if we're starting to ask them questions, like things that they don't know, they don't recognize somebody, and you keep saying, well, you should know me, I'm your daughter, can increase their confusion, which can actually cause that person to have some additional behaviors. It can be very frustrating to not be able to recognize people. It's very hard on the family when they don't know who they are. So not knowing that this is my son or my daughter or my grandson or my granddaughter. So one thing to think about is that as the disease progresses and that short-term memory loss starts to be lost, and then you have the long-term memory loss that starts to be affected. So the person tends to go back into the crux of their life, the area of their life that has a very strong memory. So it might be when they were 25 to 40 years old or something, where at that time they had children coming and going, they did the same thing every day. So they might have had, let's say, 4 children, and they got the children up every morning, fed them breakfast, got them on the bus or took them to school, came home. Maybe they were a farmer's wife, let's say, and they made lunch for their significant other, their spouse, then, for the farm hands. And then 3 o'clock comes and the kids come back from school, or you go pick them up. The children need to do their homework, so they do their homework, and then they have some supper, and then they take a bath, and then they go to bed. Same thing every day, every day, every day, every day for 15 years, 20 years, I don't know, however long it is. So that's the memory that's the strongest. So they tend to go back into that time. So they don't see themselves as an 85-year-old. They might see themselves as a 40-year-old. So if they're 40 years old and I'm just going to use myself, let's say I'm 40, I'm 85, I have dementia, and okay, I'm not 85, but I'm just pretending. So let's say I'm 85 years old, and but I think I'm 40, and my son comes to see me, and he's 40. Well, that's not my son, because that must be my husband, because it would be about the same age. This older gentleman that's in my house is a stranger, so I might get very frustrated and be fearful, and I might say, I don't know who this person is in my house, but he's here all the time, and it makes me nervous, and he needs to leave, or something like that. Well, let's say my son comes, and then they might bring one of their children. Well, that child is not my grandchild, because that doesn't make sense to me. So that child is that must be my son, I think is my spouse. So the grandchild, that must be my children. So that's where it becomes very difficult when family members aren't recognized as who they are at that age. The person doesn't recognize themselves as being 85. They might not recognize their children as being their children or their spouse as being their spouse. So um, if we explain that to the family members, that there's actual brain damage done, there's loss of neurons in the brain, and they're going back in time. So, and we're going to talk about how we go back in time with them. So that's something that we should always let our caregivers know, that this is possible, that this happens, to try to help them work through that. We want to keep the environment simple. So I'm going to give you an example. I'm going to give you a scenario where when I was working in psychiatry, my job was to go out to area nursing homes, and I did geriatric psych. So I would deal with depression, anxiety, and also did a lot of in-services on behavior management for the residents that had dementia. So we had one gentleman who he was standing at his behavior was to stand at the door and scream and pound on the wall when he saw staff members go by. So I went in and they told me I need to fix this. Well, I can't fix his behavior, but I can look at what are the triggers that are occurring around him. So I went in and I talked with the gentleman. He was a World War II vet, and he was an airplane mechanic. So on his walls, he had pictures of all these airplanes and he knew everything about them. He could tell me what type of plane it was, what kind of engine it had, all of this stuff. So as we went around the room, and he pointed out every one of his airplanes on his wall, and then we got to the one area that had the TV. Well, he's not thinking that he is 80 some years old. He's back in time where they probably didn't have remotes with their TVs. Maybe they didn't even have a TV. But he was able to tell me that this TV, I had this thing here, and he'd show me the remote, and he'd say if I push this button, I can't get it. I can't get it to shut off. I can't get this to do anything. So he would stand there, and as I'm watching him, a staff member comes by, and he yells. He doesn't yell. He says to the staff member, as he sees somebody go by, he goes, "Help me," and the person keeps going. So, and he's getting really frustrated. He forgets that I'm in the room because I'm standing kind of back watching his behavior, and he can't get this remote to do anything. So he's going to he tosses it away. He tries to unplug it from the wall, but it has some kind of a safety lock on it, so he couldn't get it to unplug. So now he sees another staff member go by. Well, the first time when he said, "Help me," nobody responded. So he yelled, "Help me, help me, help me." So now he's yelling at the person. Person doesn't stop. So again, his frustration level is getting higher and higher. Nobody's listening to him. He needs some help. He's frustrated with this TV in his room because he doesn't know what to do with it. Another staff member comes by. Okay, so he's tried to yell, and that didn't help. So now he's yelling and pounding on the wall. Then the staff member comes in, and the staff member came in and said to me, Do you see what he's doing? He's yelling and pounding on the wall." And I said, "Did you know that you're the third person who's walked by?" He tried to get attention by just saying help. The second time he tried to yell, but now he's yelling and pounding on the wall. So now he has positive reinforcement for a negative behavior. That has to change. That cycle has to change where he has positive reinforcement for positive behavior. So we had to look at, okay, when you walk by his room, just stop in, say hello, see how he's doing, seeing if there's anything that's frustrating him. But more importantly, look at the environment. Is there something in his environment that he doesn't know what to do with? Is there something in the environment that's causing him to have a behavior? It was the TV. So he doesn't look at the TV. He doesn't want anything to do with the TV. Take the TV out because he doesn't know how to use a remote, and it's frustrating for him. So we had them remove the TV. We eliminated his trigger. We eliminated that behavior. So, but to change that behavior takes some time. Everybody has to be on board. So when we set up the behavior plan, it was, okay, when you're walking by his room, just stop in and say hello. see how he's doing, see if he needs anything. Pretty soon he's going to start to learn that he doesn't need to yell out or pound because his needs are being met. Plus, his TV's now out of his room. He doesn't know what to do with it anyway, and it's, not causing him any, it's causing him frustration. It's not causing him any enjoyment. So not introducing new things. So think about where they are in that stage of the disease, and don't introduce stuff that they don't know. Don't bring in a computer. They don't know how to use it, maybe not know how to use it. So if they haven't grown up with it, they might not know what to do with it. So, okay. The next A is apraxia, and this is the inability to have purposeful body movements. So this is where we want to really consider some safety problems. So looking at the environment, doing a home safety assessment. Are there throw rugs, which are very, very hard to get rid of because everybody thinks they have to have these throw rugs because it just matches their couch or something. So do a home safety assessment. Is there a lot of clutter laying around? Do they have lighting in the hallway so that they can get to their bathroom? Is there an easy path from their bed to the bathroom? Monitoring their IADLs, which is the instrumental activities of daily living. And those are things like being able to set up their medications, being able to drive a car, being able to go out grocery shopping, being able to write their checkbook. So those IADLs, or pay bills, I should say, their IADLs are going to be lost before their activities of daily living, because you learn how to bathe, dress, and groom, brush your teeth, comb your hair, before you learn how to balance a checkbook. So the last thing you learn is the first thing that's lost. So kind of watching that kind of thing. Do they know how to turn off their stove? Do they have sensation in their hands? So many of our elders might, have diabetes or some kind of, cardiovascular symptom or disease process that they don't have a lot of feeling in their hand. So they might literally put their hand on top of the stove and not realizing that it's burning because they can't feel it. So looking at all of those safety considerations in their house. And knowing that as the disease progresses, their ability to have purposeful body movements is going to change. That they might not be able to walk anymore. They might not be able to transfer themselves. So it's things that we might have to do for them. Okay, the last A is the atypical depression. And this is different than than the regular depression, like different than major depression or depression that you might have as a younger person. What differs about this than other types of depression is there's much more irritability and much more aggression. So we might see that the person has become more irritable as the disease progresses. They become more aggressive. We might be able to handle some of that if we give them an antidepressant. And so we want to start off with something that has less side effects. Medications like Zoloft or Prozac are probably one of the best ones to use for an elderly person who has depression, who even has this atypical depression. Oftentimes, providers will choose to use like an something for anxiety, like Ativan or Valium or something, which is an antipsychotic. Those often can cause delirium, can be dangerous, can be ineffective. So wanting to start with an antidepressant, thinking about that when we're talking with our families. If they start to say they're becoming more irritable, they're becoming more aggressive, might want to talk with the provider about possibly starting them on something for that, thinking that they might have some depression. So, okay. All right, so now we're just going to look a little bit at some of the environmental interventions that we've talked about already. Doing that home assessment, considering the stage of the disease. Where are they at in the stage of the disease? Do they still remember where things are at in the house? Don't start moving things around early on in the stage because they aren't going to remember where things are at, and then you're going to frustrate them because you've moved things. So leave everything kind of where it is. Doing that home assessment, making sure that the area is clutter-free. Place some of the dangerous items out of reach. It was interesting. One time I was watching an elderly woman at the nursing home, and she was a farmer's wife, and she peeled potatoes every single day with a paring knife, not a vegetable peeler. So they were going to make lefse, which is made out of potatoes. So they had her sit down, and she was, in the later stage of the disease, but they gave her a potato and a paring knife, and she was able to peel potatoes, because she'd done that for years and years and years. It was a memory she remembered, but she couldn't remember how to use a scissors. So a scissors for her was dangerous, but the paring knife peeling potatoes was not. So, so looking at the environment, is there some things that are dangerous that we should put away from them? Simplifying the environment, like we said, making it clutter-free, looking at the all the knickknacks and stuff that are around, maybe moving them, getting them out of the way so that they don't, get aggravated and throw something and break something and then, get a cut or something like that. But again, only if that's what the person wants. If you're moving some of their knickknacks around, that might aggravate them. So, having to know your person. Like we talked about, lighted walkway, lighted stairs. This is inside and outside, so maybe having a railing there. If there is an uneven step, painting it with, red paint or something like that. So, using some signage. This is going to depend on the stage of the disease and their ability to read. So you might want to label the room, like this is Karen's room. This is the bathroom. I might want to put in the drawer that these are my t-shirts, these are pants, and not making it real lengthy. This just be one word, shirts, pants, dress, whatever. And one of the things that we've noticed is that if you look at this presentation, it's black on white, black words on a white background. Sometimes that can be difficult for the person to read. So it might be better to use a yellow piece of paper with a black on, so it'd be black marker on yellow, just because the white sometimes blends into, I don't know what it is, but they're visual problems that they have, but sometimes they can't read the black on white, but black words on white background. So maybe black words on a light yellow background, or light blue or light green or something like that. So, okay. Talked about the safety considerations. Number one thing is their ability to drive. When do we take those keys away? What is their ability to remember places? So they can still drive, they can still operate their vehicle, but do they remember how to get from point A to point B? Can they get from their house to the clinic? Can they get from their house to the grocery store? If they've lived in that town for many, many years and nothing has changed, then possibly they still can remember how to get places. If they have moved, if you've moved them from one town to another, if their grocery store has closed and it's now a furniture store, they might be going to the furniture store trying to look for milk and bread, which can cause frustration. So, and then we want to look for fall precautions. As the disease progresses, their ability to be mobile is going to change. So, watching their falls, do they need some adaptive equipment, a cane or walker? If they are using a cane and they do have some aggression, I always make sure I'm within a cane's length away so I don't get struck by the cane. Looking at those vulnerable situations, this is where we might get those telephone scams. People might call and ask for tell them that their loved one is in jail and they need to give them $50,000. And if you just give me your social security number, I can get that for you, or whatever, or what's your bank account, or, anything like that. So watching for those kinds of situations. We want to look at sensory changes and any interventions that we might need for that. So sensory devices, I don't know about anybody else, but if I don't have my glasses on, I can't hear. I don't know why that is, but it just happens to be that way for me. So do they have their glasses on? Do they have the right glasses on? Are they wearing somebody else's glasses? And are those glasses clean? So they're not all blurred and, whatever. So do they need hearing aids? Do they have hearing aids? Are they wearing their hearing aids? Do they have their hearing aid in the correct ear? Their little red dot on a hearing aid is red for right. So the red dot, the right goes in the right ear. Do they have their teeth in? And are they their teeth? I worked at a nursing home, and I remember a very frail, small woman coming down to the dining room, had this huge set of teeth in her mouth, which happened to be she walked into somebody else's room, saw teeth laying on the counter or the dresser, and she put them in her mouth. Well, they were gentlemen's dentures and totally didn't fit her, so we knew that she didn't have the right dentures in. But so making sure that they're wearing their own glasses, their own hearing aids, they have their own teeth in. Mobility devices. Do they need a walker? Do they need a cane? Do they need a wheelchair? So watching any changes in their mobility. And then the visual changes. There are visual changes that can occur as the person has the disease progresses. And one of the visual changes that I see in the nursing home setting is, and this is possibly something to watch for in their home setting also, is there a different type of flooring? So like in the nursing home, they had carpet in the hallway, and then to get into their bedroom was linoleum. So it looked like there were stairs, or it was a step up or a step down. So they were having falls in that nursing home when the residents would go from a carpeted flooring to a linoleum bathroom or bedroom. So, looking for that. We did have one woman she was a farmer, and she had a huge garden. And our flooring in that nursing home was a white background with little black dots all the way along it. But she felt like they were weeds in her garden, So she spent a lot of time either on her hands and knees or bent over picking stuff off of the floor, which she thought were like weeds in her garden. And we didn't really do much about that because she wasn't harming anybody. It was actually pretty good exercise for her because she could get up and down. But she was having some visual changes, and she maybe was also having some hallucinations. So that was back in the days when we didn't have all these different types of dementias that we know about now. So just knowing that there can be some visual changes that occur. Be visual changes from morning to night to evening. When we talk about the evening visual changes, there is something called sundowning syndrome, where as the sun goes down, the behaviors increase. So to maybe eliminate that or to make it not quite so detrimental, you like maybe an hour before the sun is going to set, turn lights on in the house, pull the drapes so that the person doesn't see that the sun is setting, but still has enough light in the house so it doesn't seem like the sun is setting. And that's difficult up here in the Midwest, in the North Dakota area where we live, that, it starts to get dark, 4:30, 5 o'clock in the wintertime. So, we might start seeing some more behaviors at 3 o'clock in the afternoon because there is that sundowning that occurs, changes in the summertime when it doesn't get dark till 10 o'clock at night. So thinking about making the environment light and bright an hour before the sun goes down so that they don't see that there's a change in the lighting and whatnot. So we talked about the neuropathy, having trouble with burns if they're cooking, also with their feet, are they able to walk? Do their shoes, are they having problems with their shoes? Making sure that they have good shoes that they're wearing so that they don't trip or fall or something like that. So, okay. These are some of the behaviors that we might see, and we've talked about some of these. So we might see some agitation, and that is pretty common. So if you think about all the things that we've talked about already, the 5 A's, we could see where agitation can be pretty common. Some of the verbal behavior, crying, screaming, being insulting, especially with somebody who has the frontal temporal disease, that the frontal lobe is where we have learned how to be appropriate in social situations. We don't just take our clothes off because it's hot, but we also know how to use a filter. So we don't want to tell people that their clothes don't match or that their hair is a mess or, but somebody who has a dementia that's affected that frontal lobe where that filter is at there is no filter, so it can be insulting behavior. What we have to remember is that we cannot take this behavior personally. So when I used to do in-services at the nursing home, I bring Q-tips out with me, and I handed out a Q-tip, and I would say to those who are listening to my presentation, I'd say, think about this Q-tip. Quit taking it personally. It's not about us. It's about the behaviors that are occurring because of their disease process. So we can't take it personally if the person insults us. Some of the physical behavior, which I've been hit and kicked and bit and spit on, where is this behavior coming from? So we're going to talk about that here in just a minute, about how do you eliminate some of these behaviors? How do you, make these behaviors less? So knowing what to look for, knowing how to look at those triggers, and we'll talk about that. Some of the safety concerns we talked about: wandering outside, driving, burns and fire, falls. So we've already covered those things. There is a sleep pattern disturbance that is mostly common with Lewy body. So we talked about this when we were reviewing some of those dementias, that a person does start having some trouble sleeping. With Lewy body dementia, the person can sleep for a very long period of time, or be awake for a long period of time, or both. So they might sleep for a day and then be awake for a day. Sleep for a day, be awake for a day. It's difficult to adjust their sleep time. We can't adjust that for them because that's their internal sleeping pattern, I guess. So, and that's mostly common with Lewy body. So Lewy body does tend to be the type of dementia that is the harder one to manage because of their sleep problems and because of the hallucinations that they have, and just that erratic behavior that they'll have. So, okay, so one of the things that we talk about is, do we do reality orientation or do we do validation therapy? And you can do both. So it depends on the type of the stage of the disease that they're in. So reality orientation is helping the person connect with their surroundings. Somebody who has mild cognitive impairment might not remember what day it is. So we can help them with that. We orientate them to their environment, to the date, the location, their current surroundings. I was just out on the reservation with one of our team members with this dementia project, and we were assessing an elderly woman who the family had asked if we'd come out and help them with some of the frustrations that the family was having with their repetitive questions and things like that. So as we were kind of doing how oriented are they to their surroundings, I asked the question, do you know what day it is? Well, right in front of her chair that she was sitting on, she had a clock that had very big digital numbers on it, and it had the date and the time. And she said yes. She looked at the date and time, and she told me exactly what she saw in there. Now, I can't assume that she knew what date and time it was, but I did know that she was aware enough to look at this clock that told her what the date was and what the time was, so she could read it to me. I asked her what season we were in. She pulled back her curtain and said, well, it's fall, because she could see outside that the leaves were on the ground and whatnot. So she was pretty good at being able to kind of figure things out that way, but yet continually asked the same questions, continually said the same thing. So she did have some memory impairment there. So, but if they're at the stage where you can orientate them without causing frustration and anger, this can be very helpful in the beginning stage of the disease, possibly in the middle stage, but as they become more confused as to what year it is, how old they are, kind of like we were talking about the woman who maybe thought she was 40 instead of being 85. So we don't want to remind them that they forgot. So if I were to continually argue with that person who is 85 years old and thinks that they're 40, I'm going to cause behaviors. So what I want to do is switch from reality orientation to using validation therapy. And what validation therapy is it was actually developed by a social worker, Naomi Field, I believe her name was. We emphasize the feelings behind the behaviors or statements. So if the person's on the farm and they're talking about, I got to get out to the field, I have to, bring my husband, wife, whatever, their meal, talk about that. So, where are they at? Oh, where's your farm at? And boy, how long did you farm? What kind of crops did you have? So you can maybe get them off of the topic of thinking they have to leave to go do something, where they start talking about, oh yeah, well, we've been farmers for 25 years, and we are beet farmers, or whatever. So validating where they are can hopefully prevent some of that agitation and some of that aggression. Sometimes you have to do the same thing over and over and over again. So one thing that I remember when I first started working with this disease was I was working at the nursing home and new to taking care of people with dementia. And this gentleman came up, and his name was Bill. And I was told by my supervisor that when Bill comes to the nurse's station and asks for his mother, I am to show him this scrapbook that has his mother's obituary, and tell him that his mother has passed away. So I did that. So every single time Bill came to the nurse's station and asked me for his mom, I would say, oh, well, Bill, here's her obituary. Remember, she died 20 years ago, so she's no longer alive. Then he would leave, and he would cry, and then he'd come back about 5 or 10 minutes later and ask me for, where his mom is. I'd continue to do this for 5 or 6 times. And finally, one of the CNAs came up to me, and she's excellent at working with people with dementia. And she said, stop it. You're not helping the situation. You're making it worse. Every single time he comes up and asks where his mother is, you're causing him grief. He's having to relive the fact that his mother's passed away, and it's not helping. So she said, what you need to do is figure out what is it that he wants from his mom. And she should have came up with this therapy, because she was really good at it. So she would say, ask, what we're going to do is we're going to meet those 5 basic needs. Is he hungry? Is he thirsty? Is he in pain? Does he have to go to the bathroom? Is he tired? So she would say, Bill, you want this cracker or this sandwich? And then he would take whatever it was, and then he'd go away. And then he'd be gone for a while, and then he'd come back and he'd ask for his mom. And we're like, okay, so what is it that the mom provides? So the mom provides nourishment, nurturing. Does the mom help him if he has some pain? So trying to meet his need without continually causing him grief, because I was trying to do that because that's what I was told to do. So not using the reality orientation in that aspect, but using the validation therapy worked so much better for him. Okay. Another type of behavior management that is very helpful is the antecedent behavior consequence of behavior management. So the antecedent is the person has a behavior, finding out what happened, everything that happened prior to the behavior. The antecedent should be very detailed. So person, and I'm just going to use an example of, we had a gentleman who he was living in the nursing home. The nursing home was very large, so he would wander around, and he would urinate anywhere, mostly in the dining room, and like somebody's water pitcher or something like that. So that was his behavior that we had to fix. So what we did was use this antecedent behavior. So everything that happened prior to the behavior. So where was he at? Was it always in the dining room? Was it always with a flower or a cup or whatever? What was going on? What time of day was it? What was he doing prior to this? What staff were on? So everything you could possibly think of that happened prior to the behavior. Well, it wasn't as simple as being in the dining room. He would do this anywhere. He'd wander around, and we would see, okay, well, he's urinating just in the wrong spots throughout all the different units. But what we found was that when he touched his belt buckle, that was when he had to go to the bathroom. So that was the antecedent that we could pick up on by tracking his behavior. And we saw, okay, this is the trigger. He touches his belt buckle, then he takes his pants down and uses the bathroom. So we told everybody in the nursing home, when this guy comes walking around and he touches his belt buckle, get him into the bathroom, and then give him a positive consequence. So we need a positive reinforcement for that positive behavior. So that it's very helpful. It's time consuming, but it will help you figure out what the behavior is, what the trigger is for that behavior. And you can hopefully help reduce that behavior or even eliminate that behavior. So Okay, some of the pharmacological interventions that are used for people that have dementia are some of these dementia medications. So, and I can't pronounce them very well, so I'm just going to let them be up here. So we have Aricept, which is can be used for all stages of the disease. And then we have Razidine, which is usually used with the mild to moderate stage, as is Exelon. It's not uncommon to be put on more than one or two of these. Namenda, we usually see in the moderate to severe stage. One of the things that I was told by the Aricept representative, and also was brought up at many different conferences I've been to about any of these medications, is that we know that the disease is going to progress. But if you put them on, and let's just use Aricept for example, if you put them on Aricept, and we talk about that hill that the person goes down as the disease progresses, well, instead of going down that hill too fast, Aricept will keep that hill not quite as steep. So they'll hang on to that memory for a longer period of time. So it slows the progression down. It doesn't stop it, but it can slow it down. If you take that medication off at any point in time, that person is going to deteriorate right down to where they would have been without that medication. You cannot get that memory back. So even as the disease progresses, sometimes providers will say, well, let's just take this medication off. Or what I had happen one time was, had a woman that was on Aricept, and she was starting to, she hung on to that memory for a long time, and then she started to kind of deteriorate a little bit, and the family said, well, let's take her off her medication, let's take her off Aricept. So they did, and she deteriorated very quickly right down to where she would have been without that medication. So then they said to me, well, can you put her back on it so she can go back up to where she was? Well, you can't. You can't get that memory back. So that's just something to think about as far as the using any one of those medications. Behavior management, anti-anxiety medications can be given. Antipsychotics are given. Mood stabilizers. Back when I was prescribing, I tried very hard to stay away from the anti-anxiety medications, the Ativan or Valium or any of those medications, the benzodiazepines, which can cause a lot of confusion, cause delirium, can cause falls. I also try to stay away from antipsychotics. And I tended to use more than mood stabilizers, which are actually in the seizure category. So things like Tegretol or Depakote seemed to work better as far as mood stabilizers for behaviors. And then for the depression, usually use antidepressants that are in that selective serotonin reuptake inhibitor, the SSRIs, do work better for the elderly, less side effects. Tried again to stay away from the anti-anxiety medications. There are antidepressants that do have an anxiety component to them, so that might be the way to go. Any one of these medications need to be titrated down instead of just abruptly stopping, because to eliminate any side effects that can go along with that. So knowing that medications do not cure the disease, but it can slow the progression down. So this is the end of the presentation. I hope you found it helpful. I would like to point out our Spirit Lake Senior Services Dementia Capability Project team, and we are located out at Spirit Lake, which is 15 miles out of Devil's Lake, North Dakota. Iris Walking Eagle is our dementia project coordinator. Eric Dubois was our dementia training coordinator and our outreach person, but he has since left the program to pursue other things. So Shaylin Damaris is now our current dementia training coordinator and our outreach person. Vanessa Thomas is Spirit Lake Senior Services Program Director. And myself, I'm the project educator. And again, I work out of the University of North Dakota College of Nursing and Professional Disciplines. And we have Loretta Hewer, who is our project evaluator, and she's from North Dakota State University, which is 70 miles south of the University of North Dakota. So here's our references that we have used, and 2 slides on those. So that concludes this presentation. I hope you enjoyed it, and thank you for listening.